Our next talk is Updated Carotid Stenosis Criteria May Support a Reduction in Healthcare Expenses by Dr. Villacresis of the MUSC team.
Good evening, and thank you for the opportunity to present today. There is currently a lack of standardization for carotid duplex criteria among vascular labs across the U.S. The Society of Radiologists in Ultrasound previously published recommendations based on expert opinion, but these were without a standard for comparison. More recently, the Intersocietal Accreditation Commission updated their duplex ultrasound criteria recommendations based on a retrospective study comparing duplex ultrasound versus catheter angiography for diagnosis of carotid artery stenosis. Results found that specificity, negative predictive value, and accuracy of duplex ultrasound was improved by raising the peak systolic velocity threshold to greater than 180, or by adding an additional parameter of ICA to CCA ratio greater than 2, in addition to peak systolic velocity greater than 125 for carotid artery stenosis greater than 50%. The SVS currently recommends yearly duplex ultrasound surveillance for greater than 50% stenosis using an IAC-accredited vascular lab. Therefore, how we define 50% stenosis has significant care implications. Previous studies have shown that yearly duplex ultrasound for surveillance of asymptomatic carotid artery stenosis can be costly and inefficient. Consequently, the new IAC velocity recommendations may have a cost impact to the healthcare system. However, no prior studies have been done to show differences in healthcare cost based on the stricter IAC recommendations. We hypothesized that increasing our vascular lab velocity criteria for carotid artery stenosis of 50 to 69% would significantly reduce our institution's healthcare expenses. Our vascular lab adopted new duplex ultrasound criteria guided by the new IAC recommendations in May of 2021. Our threshold for carotid artery stenosis 50 to 69% is a peak systolic velocity greater than 125. Based on IAC recommendations, we added the additional parameter of ICA to CCA ratio greater than 2 for 50 to 69% stenosis. We then performed a retrospective review of all the carotid duplexes performed at our vascular lab 6 months before and after our criteria change in order to perform a cost analysis. Outcomes of our cost analysis included the cost of a duplex ultrasound and of a complex clinic visit, which can be seen here on the right. We also looked at ultrasonographer time saved by reducing time spent performing carotid duplex. Exclusions are shown here on the bottom. Our results showed a significant increase in the patients with less than 50% carotid artery stenosis in the 6 months after our criteria change as compared to the 6 months prior, as well as a decrease in both the number of patients meeting criteria for 50 to 70% and greater than 70% carotid artery stenosis. Based on the significant decrease in patients meeting greater than 50% carotid artery stenosis and the estimated cost of our duplex ultrasound and complex physician visit, we calculated a yearly savings amount of $168,256. Additionally, we calculated 74 ultrasonographer work hours saved on a yearly basis. Limitations of our study are seen here, which include being a single-center retrospective data review with a limited 6-month before and after timeline that was extrapolated to 1 year for cost analysis. We also could not account for differences in ultrasonographer technique. In conclusion, lifelong surveillance for asymptomatic carotid artery stenosis at greater than 50% is a considerable healthcare expense. Recent changes in duplex ultrasound recommendations may have a broader impact than just the disease process itself and could have a significant reduction in healthcare cost burden. Future directions include assessment of actual costs through medical record review, tracking progression of carotid artery stenosis in patients diagnosed with the stricter criteria, and application of screening and surveillance guidelines within our local community. These are our references. Thank you. I'll take questions now.
So while people are coming up, so you changed your moderate stenosis definition, but your number of severe stenoses went down. So why is that?
Yeah, that's something that was a surprise to us whenever we did our data review. We have not really yet been able to explain why that might be. So I don't have a great answer for you, but that is something that was a surprise to us.
So you have an interesting group of patients now that had some evidence of carotid disease that have now been reclassified as having insignificant disease. So are you telling them to not come back ever, or are you increasing the surveillance interval? And what do you think about the potential implications of somebody like that coming in with a stroke potentially?
Yeah, I think that's a great question. Our practice is also, I will say, very dependent on preference of our physicians. But what we are suggesting with our study is that those people who fall out of the greater than 50% stenosis would not have to have yearly follow-up. And unfortunately, we don't know what data there might be suggesting whether those, who might come back with a stroke, which I think would be an interesting study. But the recommendation right now is that yearly surveillance is only for greater than 50%.
Yeah, it's an interesting thing. Like, I think very few of those patients are going to have strokes, obviously.
Right.
Pretty moderate to mild disease, but they have evidence in their chart of having had carotid stenosis and now have sort of been reclassified. It's just a very unique situation. Thanks.
Jonathan Cardella from Yale. That was fabulous. Congratulations. Really well done. In light of the latest CMS approval of transfemoral carotid artery stenting, is it time that we look at these guidelines across the board? Now, again, this is not your study, but it's just a question, because my concern is that, it's going to be transfemoral carotid artery stenting is going to be done, like crazy. So should we be changing the sensitivity for 70% as well?
So that is something that the IAC study attempted to look at. Unfortunately, they did not have enough patients in their study to be able to really validate the more severe stenosis. But absolutely, I think that's something that is currently being looked at. There's just not enough patient data yet.
Remember also, CMS is not allowing you to intervene based on ultrasound alone. So you have to have a second modality, either a CTA or an MRI or MRA to confirm.
No, fair, but one of her thesis statements was the cost savings.
Sure.
So, that means,
Yeah.
Very good presentation, and a question that we struggled with at our institution, because we have majority of the labs are run by vascular surgery, where we have our own internally validated criteria we've been using for years, and our numbers are actually even higher than what the IAC recommended currently. So, but our cardiology group uses the lower threshold, so it has raised a little bit of a question that Dr. Stern brought up about what do you do with these reclassifications. The question I have is, when you were looking at the background, I haven't been able to find this, and it might exist or it may not exist. Do you know the percentage of labs that are IAC accredited that are the independent validated criteria?
I do not, no.
And I hate to hijack your talk, but in the group, are there, how many people use their own internal validated criteria still? Am I like okay, there's a good number? Yeah, okay. So, and did your lab correlate with what the IAC showed, or are your numbers still like higher significantly than what because we're like in the 140 for the 50%, and we're 280 something or 290 for higher than that. So what are you correlating it to? CT, contrast angiography, MRI. So if we have other angiography, every year we take all the patients that had their ultrasonography and we compare it to the CT scans to get the percentage but before that, years ago, we did, a ROC and all that and got our initial numbers, but we continue to make sure that they still correlate. Because new equipment changes, sonographers change, right? So, yeah. So anyway, for us, it didn't impact our practice, but just.
So we're saying the standard of care for these patients is medical management, your surgeons, and you're not going to follow them again. So who's medically managing them and making sure that they are on an aspirin, a statin, they're not smoking, and hypertension's controlled? Because I feel like this is the biggest reason why we keep following even mild stenosis, because their PCPs won't make changes.
Yeah, I think that's a great question. And I think that this, any recommendations going forward and the impact that these kinds of studies need to look at making sure that there is that sort of follow-up and relationship with primary care physicians in order to ensure that if we actually have an effect on the patients that we're dropping out of our follow-up, that we have a set plan for them going forward.
All right. Thank you.
Thanks.